as well. Okay, can everyone see that on their devices?
Yeah.
Yes.
Yeah.
Okay, brilliant. Right, we will crack on in the interest of time. So thank you very much, everyone, for joining. So this is the third of our campaigns focusing on lung cancer. This one is slightly different, just to give you a heads up in advance, because before we've been looking at kind of general awareness programs, but for this particular campaign, what we're focusing on is lung cancer screening, which is a kind of discrete system that you're invited into if you meet a set criteria, which our colleagues are going to talk about in more detail, but it's not a kind of general awareness session. Saying that, we are going to signpost you to some other resources that you can use throughout the course of the month, and Grace is going to give you the kind of 101 on the clinical background of lung cancer as well, so we understand both kind of the symptomatic and asymptomatic versions of lung cancer and how we can identify those going forward. If I just click onto my next screen, I'll give you a quick overview like we always do. So the campaign title, and again, I have to caveat here that it's still a bit of a work in progress. So the dates are slightly different for this one. Whereas they've been the kind of calendar month for the last campaigns, we're actually starting this campaign in earnest on the 10th of November. That's for a variety of reasons, but some of which are actually booking the advertising spaces and what's available. That's kind of how it's slotted into our planning. So we'll be running the campaign for 4 weeks, starting on the 10th of November. So I would ask that any kind of activity that you put out on social media or any events that you're running don't take place until after the 10th of November, so it's all coordinated. The focus and the kind of tagline for this campaign is still here, and the idea is that you've attended lung cancer screening, which means that if there is an issue, it's caught early and you're still here for the loved ones and people in your community. I'll go into the details of the campaign assets at the end of the webinar, like I always do, but just to kind of give you an idea there. What I also would like you to be aware of is that November, the whole calendar month, is Lung Cancer Awareness Month, and that is why we kind of originally picked this time of year. With that in mind, we'll give you some links to other assets so you can talk about symptomatic lung cancer as well. But I know you're all here for the kind of clinical input and advice. So we're very lucky to be joined today by colleagues from InHealth. So InHealth are the provider who lead on the lung cancer screening programme across all of West London. And we have Grace Camfield here, who is a clinical nurse specialist, and we have Katie Downs, who is the engagement and ops manager. And they will be going through the next series of slides with you before we kind of circle back. As always, if there are any questions, we'll have a little bit of a break in between, and please do pop your hand up. So without further ado, I'll hand over to both Grace and Katie to give you a bit of background on lung cancer.
Perfect. Morning, welcome everyone. I'm obviously Grace and I work for InHealth, so I lead on the clinical aspect of our screening programme within London. So I just thought I'd start with some statistics about lung cancer, because obviously it is one of the biggest causes of cancers and deaths, and that is because prior to obviously our screening programme, lung cancers aren't normally caught until stage 3 and stage 4, which normally means that patients have not a great outlook on life, nor do obviously it's untreatable essentially when it's 3 and 4. So as you can see, 57% of lung cancers are normally diagnosed at stage 3 and 4, but people diagnosed at stage 1 through our screening programme, they have an extra 5-year survival rate. So the difference that we make through this screening programme is obviously massive. Out of 100 lung cancers, 70 plus is all related to smoking, so that's why we're quite heavy on our smoking cessation as well. And there's a link there if you want to know more information about our lung cancer screening programme, but I will talk about it in the later slides. And there's also a link at the bottom for Roy Castle, because we are heavily we heavily work with those guys around all of our programmes around the country to deliver this programme and to raise awareness. So please do go and have a look at their website when you've got a second. It's really informative. So I just want to talk about some of the key symptoms of lung cancer. Quite important, because some of these symptoms can be masked by what patients perceive a common cough and cold, but actually from the list that you can see there, it could be a common cough and cold, or it could be the first sign of lung cancer. So the three in bold are the ones that we particularly become more worried about. For us, we call them red flag symptoms, and that's because they are the top three symptoms of lung cancer, minus a cough and cold, what people think. So obviously a persistent cough that lasts 3 weeks or more, a cough that's outside of that patient's normal remit. So if someone had COPD, for instance, and said, oh, I always have a cough, okay. But if it was worse for that patient and lasted longer, that's when we would be quite concerned. Obviously feeling breathlessness as well for no reason at all, that's a worry. Repeat chest infections. When we say repeat chest infections, we say 3 or more chest infections within a 2-month period. Just that's not normal for any patient particularly. The other ones not so concerning as the top three, but we do take them quite seriously. So obviously losing weight and loss of appetite that's not already under investigation, coughing up blood or blood in your phlegm, which is your spit. And again, not just the one time, but like ongoing. So like 2-3 times a day, maybe lasting a week or more. A cough that changes or gets worse. So goes from dry to wet or wet to dry, persistent to non-persistent. Unexplained tiredness and lack of energy outside of that patient's normal remit, and chest and shoulder pain. People don't tend to think that this could be related at all, but when you've got some of these symptoms, or if you've got early stage lung cancer, it can affect, because where it's in your chest, it can affect your chest muscles and chest wall, and then obviously you have pain radiating in your shoulders. So people don't often think that's a common one, but it often is. Some other less common ones we've listed there. So it's back pain, wheezing, a change in your voice, finger clubbing. That's where the tips of your fingers swell around your nail without any known diseases. Difficulty swallowing, or a swelling in your face or your neck, because that means it could, the cancer that could potentially be there is affecting your lymph nodes in the neck. So they're just ones to look out for. So we always say to our patients, if you've had any of the above for 3 weeks or more, please visit your GP, or if they are part of this program, they are very welcome, once I've explained how it works, to ring in, and we can push through patients through the telephone triage who are worried about their symptoms. But yeah, next slide, please. So just some risk and causes of lung cancer. I think, as we know, because we talk about it all the time, smoking is the leading cause of lung cancer, and it's for 70% of all lung cancers. This includes all types of tobacco products, and I often get asked as well, any recreational drug use that is mixed with tobacco products, that does count as well. So if patients say, I don't know, they smoke crack, or they smoke marijuana, okay, but if it's mixed with tobacco, that makes them at risk as well. So we include those products, anything that's tobacco related. We also know from patients living in the most deprived areas of the country are most at risk, and this is due to health inequalities and their social aspects. We also know the more that patients have smoked over the years, even if they have reduced now, but when they started, because I mean, the patients that we see over 55, of course, they've started when they were 14, 15, 16, and they could smoke between 20 and 25 a day, but now that potentially they've cut down, all of those numbers over the years really does put them more at risk than, say, someone who smoked 2 a day for 10 years. So this is why our program is so prevalent and important to target those individuals. You can, not that we include at the moment, but we are obviously updating our systems, but secondhand smoking is also a cause, and that is a worry for a lot of people, because I know back in the day you could smoke in pubs and venues, and if you weren't obviously a smoker yourself, you were surrounded by the smoke. Again, the toxins of those chemicals can affect people later in life. We call that passive smoking. Yeah. Some other risks to think of as well. So we do take family history into account. So that is mum, dad, brother or sister. And that's if they've obviously smoked throughout their lifetime as a child, and then they've grown up, say the adult patient has grown up, they are also at risk of like taking on smoking themselves, which we'll talk about. Exposure to workplace chemicals. So asbestos, coal, nickel. We've done some work recently, Charlotte and Katie, on our military patients, because we know patients in the military are exposed to all kinds of chemicals whilst they're doing their work. So we've done a little work with those groups of people as well. And then other bits such as construction, manufacturing, mining is massive. Firefighting, obviously all those fumes, bricklaying, farming. Other exposures can be gas and diesel fumes. Patients probably aren't aware of this, but I did recently go to the lung cancer nurse conference earlier on in the year, and there was a really good talk from one of the professors how our air pollution does have chemicals in that can contribute towards causing lung cancer. It's only a very small amount, so it's probably 1 in 10 via air pollution, but it is still really important for people to understand that that does have a big effect as well and can cause a risk to lung cancer. So that's why it's super important to come and be checked with us. Next one. Obviously, we know there are some lifestyle risks as well. So we know that the people living in the most deprived areas, they probably don't eat well. They probably don't exercise and look after their overall health altogether. And that will contribute towards cancer. So it's like processed meat, alcohol, all the bad things that we are told are bad, without then having some healthy parts on the side, i.e. exercising, eating your fruit and veg, having enough water in your diet, etc., etc. And as you can see there are some studies that have found that people who don't exercise or sit for a long period of time they do have an increased risk, and that's just because they're not physically active, so their body is screaming for some health and well-being. And we do find those in the least deprived areas obviously have this kind of lifestyle, and that's why we like to support them as well, to have a better lifestyle. We don't just do lung cancer screening on our mobiles, we do lots of other leaflets, posters, signposting for a healthy lifestyle. We also do mental health as well, because that's another big cause as well. Next slide. So just talking about what tests and examinations if you've got any symptoms. So on our unit we do a low dose CT scan, but if a patient was to go to their GP not via our program, they could be sent for a chest X-ray or a normal CT scan. So a low dose CT scan is a lower dose of radiation, whereas if a patient was to have a normal CT dose in the hospital, the radiation is just slightly higher. So that's the differences between low dose and normal. But as you can see on the side here, some top tips to help patients to prep for their appointment. So your smoking status, and how long you've smoked for, and the smoking number, being true about that will really give us a reflection of whether you're high risk or low risk. Obviously your family history of lung cancer and bowel cancer, if they can remember that. Their latest weight and height as well. Again, this can be guessed, because when we see them at their face-to-face appointment, obviously we do these bits which I'll talk about. Any alcohol intake, if they do drink, if they've got any learning disabilities or mental health conditions. This is just so that we can offer any additional needs should they come down to visit us. And the same with mobility and physical impairment. We've got an internal accessibility policy that we use to give all patients the best chance of being invited and scanned with us. So lung cancer screening. So what is our programme? So obviously, you know, we're here to diagnose lung cancer nice and early. And It's to try and diagnose at stage 1 and stage 2. So we target patients 55 to 74 who are current smokers or ex-smokers or ever smoked in their life. So they could say, I did it for 2 years when I was a child, but no longer. They would obviously still count. And they obviously have to be registered with the participating GP. That's Charlotte and Katie's domain. But yeah, we obviously get the patient's data from their GP. It goes into our internal system, and then that's when we can invite patients. So currently, as it stands, 75% of people who have gone through our lung cancer screening program, we've caught their lung cancer at stage 1 and stage 2, which is a massive improvement nationally as well, considering 3-4 years ago it was all stage 3 and stage 4. Now we're able to catch it at stage 1 and 2, treat it, and then patients are still able to live the life that they so wish to. So what to expect with us? So patients will receive a letter in the post if they're with a participating GP to be invited. They'll first have a telephone triage with a healthcare advisor, and they will ask just about their smoking history and respiratory history. They'll mark that on our internal system. And then that will tell us if the patient is low risk or high risk. If the patient is low risk, they will be re-invited every 2 years. So they'll stay on the programme, but they'll be re-invited every 2 years, and obviously then we'll re-triage them. If the patient is high risk, there and then the PCA is what we call them, patient care advisor. They will book the patient in for a face-to-face appointment to see a respiratory nurse on one of our mobile sites. And then the patient will attend a face-to-face appointment. So when they attend the face-to-face appointment, they're greeted by the HCA, height and weight is taken, and smoking cessation conversations happen to every single patient who is a current smoker. Once they've seen the healthcare assistant, they'll go and see the nurse, and then they have a 10-minute appointment with the nurse who goes through the triage questions that were previously done on the telephone, and then we ask some additional respiratory questions. So we ask about any signs and symptoms they're worried about from the slides previously, any red flag symptoms. We ask them about their cardiac health as well. And then that form will tell us that the patient is high risk. We'll select yes, and the patient will go into the unit straight next door, and they will have their low dose CT scan. It takes about 3 to 5 minutes. Very nice and quick. Any questions on that first part?
It's not a question, Grace, but just to add to your point around lung screening. So just for everyone's kind of understanding here, so we're all quite familiar with cervical, bowel screening, some of the big national campaigns, but lung cancer screening is fairly new, and actually we've only just started using that terminology in the last kind of year or so. Before, they were referred to as targeted lung health checks, and they've kind of been going through a staged rollout process across all of England. In our patch that we cover our own partners, so Southwest and Northwest London, we've now rolled them out across all of our boroughs in participating practices, but it is a new screening program, and it's very much been driven by the stats that Grace has quoted there about the chances or the percentages of being diagnosed at stage 1 and stage 2 are exponentially higher in terms of life outcomes and survival. So it's really kind of pushing forward and shifting the dial on that. I just want to be very clear in terms of the two routes. So that cohort of people who are in the 55 to 74 bracket will and have smoked or have ever smoked will routinely be invited by their GP practice in a proactive way to attend screening. Any of the other symptoms, the normal route remains. So you would present at your GP practice with your concerns, and they would go through a slightly different I guess referral pathway to follow that up. The screening mobile units that were flashed up on the screen there, you may have seen them kind of round and about. I'm not actually sure where they're all based now. Katie,
everywhere.
Everywhere. Okay. So I think they were in supermarket car parks or sometimes they're one of those ones, a bit like blood vans where they move around. I think we also have some based within hospital areas. So we call them rapid
CDC.
Yes, so cancer diagnostic centre. So we have them based within acute settings as well, but I think they are primarily those mobile units. So if you do see them, kind of keep an eye out for them. Grace is now going to talk about, so we've been weaving in these kind of prevention elements into all of our campaigns, and what we're obviously the direct link with lung cancer here, and the stat being so high that 70 out of 100 are linked to smoking. And we wanted to talk about smoking cessation and what's available for people across West London. So I'll hand back to Grace.
Mm. So just some facts here around obviously smoking. So teens of parents who smoked, they are 4 times more likely to take up smoking. I think that was just how it was back then. It was very, very prevalent back in the day. It was a very common thing, and that's what our patients tell us. It was such the norm to smoke. Everybody took it up. Everybody was smoking at school, college. Everyone was smoking at work. And obviously, if some patients have said to us that when they've had children, they have noticed that their children have also taken it on quite early because it was such the norm back then. So I think that's quite important to note with our group of patients. Obviously, we always talk about our patients giving up smoking. We try and help them as much as possible. Of course, some patients just don't want to. They're quite happy as they are, but others would like to see the positive benefits from it. And there is a good financial gain there, as you can see. You can save £49 a week quitting smoking, which is £2,500 a year. For our patients in the most socially deprived areas, that would make such a huge difference to their lives if they could see that back in their back pocket instead of smoking. So when we have our conversations on our mobile units about smoking cessation and giving up smoking, and all of our leaflets and posters, we try our best to make it a really positive influence. And sometimes the stats like patients see when they come in, they're shocked, and sometimes that's like, yeah, I'm gonna give up smoking because I didn't realize I was spending that much money, etc., etc. It's also probably worthy to note, people probably aren't aware of this because I think it smells so sweet or something is what people were saying, but people who smoke shisha, that is actually equivalent to smoking 100 cigarettes, to bear in mind. So I know some parts of London shisha is so prevalent and it's a really big thing. So on the flip side of that, if they were to have a session, it's like smoking 100 cigarettes, which is a huge number to do in one time, because I can't imagine a patient smoking 100 even in a day. So that would be that's quite a tough stat, that is.
That's quite a lot.
Yeah. Obviously with smoking can also increase the risk of blood clots and type 2 diabetes, which I don't think people are aware about these days. And obviously 80% of tobacco smoke is invisible and has no smell. So with those chemicals, people don't know how far it spreads. I mean, I had a patient say to me one time, yeah, but my roll up is so slim, there's nothing in it. But the chemicals in tobacco products as a whole is so harmful, and that is what damages the lungs on the inside and causes all of these respiratory conditions that we see and lung cancer. So yeah, I just wanted to put some stats on there for you. So we are massive on patients quitting smoking. Obviously, if they agree, we don't force patients on the unit, and we don't try and sway them in any way possible. We have those positive engagement conversations with them. So we try and make them see the benefits. Obviously, there's the financial gain. Then we also try and help them with their physical health, so their heart health, mobility, like being more physical. A lot of our patients say, yeah, I want to be around for my grandchildren more. A lot of our patients, where they're in that age category, they're worried they won't be around to play or see their grandchildren. And that's what our patients drive to give up smoking, because they're like, I've had enough, I've done this 40 years. I want to see like children and grandchildren grow up. So yeah, we try and get them to see the benefits from a whole, not just if you give up smoking, this is going to be good for you. If you give up smoking, your heart will be better, your physical health will be better. Some patients have even commented that their mental health feels better. They're able to go out, do more They think a bit more freely. They're not feeling as they used to before. And then some benefits is also obviously your smell and taste improve, you breathe more easily, and you have more energy as well. And if they were experiencing any of the symptoms prior, and even though they were clear for lung cancer, for example, those symptoms will also clear up as well. So like a cough, breathlessness, tiredness, even though a patient could come back clear for lung cancer, if they were to stop smoking, those symptoms would also disappear because the body kind of repairs itself from the day that the patient gives up, essentially. So we always quote this as well to our patients because this also helps them. So after 1 year, your risk of heart attack halves. After 10 years, obviously your risk of lung cancer falls. And after 15 years, your risk of heart attack falls the same as someone that's never smoked. So we obviously patients that give up, we've got a really nice poster in the cabin from NHS. There's a really nice timeline of how, when they give up, how they feel over the next 3, 6, 9, and 12 months. And so when they see those stats on the wall and they could see a good recovery of quitting smoking, that also makes them want to quit as well, because they could see that in a year's time they're going to feel so much better on all levels. If patients quit smoking nice and early as well, as you can see, they're less likely to develop type 2 diabetes, bone disease, which is known as osteoporosis, which we often commonly see through the lung cancer screening program, eye disease, and dementia. And people don't really put dementia and smoking as a relation, but what you've got to think is the toxins and the chemicals that are being smoked isn't just affecting the lungs, it's affecting all of the organs in the body. So it will eventually damage all of it in the heart, in the brain, and then that's where all the other health risks come out as well. So the earlier that patient can stop smoking, it is going to be so much better for them in the long run. And that's what we try and support them with as well, with other community referrals and signposting them to other community help. So obviously, what can we offer? So we offer a comprehensive smoking cessation program. I will let Katie explain a little bit more because she's led on this in a minute. We know that nicotine is highly addictive, and we know that patients the patients that want to give up are really keen on the nicotine replacement therapy. For the life of me, I can't remember the patches, but they really helped patients previously. Is it Champix? So we had a lot of patients.
I think it's been rebranded now.
Yeah, so they liked that because that patch used to help them give up smoking, and they never ever went back to it. But we have found since that was taken off the market, the patients that we were speaking to and were trying to offer smoking cessation to, all they wanted was to give up smoking via the patch. So I'm quite glad to see that something has been rebranded and coming back in, because we had a really good uptake when patients knew that was what could help them, because a lot of them have come back and said the therapies that are out there, they just soon go back to smoking because they don't feel it helps them enough.
I think the Champix was their medication, was the tablets.
Yeah.
And I think that's been rebranded, but I think that the patches have always been available, but they've now sort of really, honed in on them so that they're, really working for people.
Yeah. A lot of patients do ask us about vaping. As we all probably know, there's nowhere near enough evidence behind it. We don't know the risks and the benefits. So it's not something we would openly say to a patient that comes in, yeah, please go and buy a vape. We never openly say that because we never want to recommend another form of quitting smoking by putting more dangers into another patient. So we always try and refer them through our program. And if they want to take up vaping, that has got to be patient choice, but it's not something that we would say, yeah, we totally would agree with, because the research is just not there to make it safe enough.
So through our screening programme, RMPs have supported us by putting in place 2 smoking cessation advisors who will be able to access our system and pick up the patients from the previous day, previous week, previous month, who have expressed an interest in smoking cessation. They will then telephone each patient individually and have a conversation with them about their needs, about, you know, the best way to approach smoking cessation with each individual. The advisors will then are in touch with all the local support, and they will then hook up with them to send the patients directly to them and get the best outcome in smoking cessation as quickly as possible. It's quite a new pilot within our pilots, but at the moment we're getting some really good results of people that are quitting smoking via getting this call the next day after their telephone triage or their face-to-face appointment. So that's basically how we're tackling smoking cessation through the lung cancer screening programme at the moment.
Yeah, and this new this new thing that Katie is working with, we've been very lucky that on our internal system we've been able to also target the low risk patients from telephone triage. So because the low risk patients at telephone triage, they often say to us, but I still want a smoking cessation referral. Am I going to miss out on that because I'm not seeing the nurse face to face? So what we've been able to do is still refer those low risk patients for smoking cessation so they don't miss out. So we see the low risk patient and the high risk patients, they're offered both the same. Steph?
Yeah, so it's an absolutely fantastic kind of new resource. So wherever you sit on that risk scale, there is now a program in place, and it is a really kind of comprehensive, proactive program to support people to stop smoking. The other thing I just wanted to really drive home is our kind of position as a Cancer Alliance around vaping. So whilst for some programs it is offered as a kind of short-term aid or a step down between smoking, we would absolutely never say to anyone that it is a something that you should start doing if you haven't started, or that it is any really clinically anyway safer than smoking. I think we're saying this because the evidence and the research just isn't there yet. People have only been vaping for maybe max 10 years, and we don't have the long-term studies. We don't have the research to understand the real effects of this. And similarly to shisha, when we talk about the flavors, the marketing around vapes has been so aggressive in terms of one, targeting at children, but also making it feel not taste like you're smoking a cigarette. So people mentally kind of disassociate between the harm that could potentially be coming from that product, as opposed to smoking. I think we probably all deep down know that what we're having isn't good for us. So it is available as a short-term kind of step down offer, but absolutely, if you're having conversations with your communities, it's not something we would ever advocate as a kind of positive health tool.
Thank you.
And
yeah. Oh yeah. Lastly, we also refer our patients through Stop Smoking London. So this is our nursing teams on the ground in all of our cabins and sites. We also can refer patients to Stop Smoking London, which Katie and obviously Steph know more about. But yeah,
it's a really, really useful tool. Basically, if you are somebody that smokes and you're looking to quit or to stop smoking, to use a different terminology, it's tailored very much to each borough, to each area. So you log in, you go onto it, and I've spent quite a lot of time on it actually, because it's so useful to each area. They'll be able to point out exactly where you go if you need some NRT, some nicotine replacement therapy, or you want to go to a group. There's literally something for everyone. So I think that using this sort of resource and the personal resource that you'll be getting from the smoking cessation advisors, I feel that we are giving our patients every chance we can to support them with smoking cessation should they wish to follow that pathway, which obviously we would encourage.
Yeah, absolutely. And it is a self-referral system. It's open to anyone. So after the webinar, as per usual, I will send you all the links. So please do familiarise yourself with that. It's a great thing to
Really
be shouting about out in the community. Grace, I think that was your last slide. It is.
Yeah.
Yeah. Thank you so much, Grace and Katie, for that.
Okay.
Does anyone have any immediate questions before I go into the campaign resources?
Yes.
Yep.
So for the non-smokers, so any methods for them to see about the lung cancer screening or early detection? As first question. And second question is that about the diagnosis. And I understand some cases that even the X-ray may not show the possibility of the lung cancer. And I have one case is that my friend is that only after detection of suspicious cell in the sputum, then the doctors found that it is lung cancer rather than from the X-ray. So is it a very typical diagnosis cancer for lung cancer?
No. So if the patient goes via the GP referral way, not through our program, the GP and the patient has got any of those symptoms of lung cancer, then they would be sent straight away for a CT scan, not an X-ray. And then on the CT scan, you can detect it because we call them nodules. So they're like, well, they can be any sizes, but on the CT scan report, when we see it, they're like, it would be like a big white circle, probably be like a 50p coin. And we could see that very clearly on the lungs on a CT scan because it will just pop out just like that. So when we see that, what the radiologists do is measure the sizes and it gives a percentage. And if the percentage of that, what we have seen, goes over the national numbers, that patient is referred instantly into the respiratory team for lung cancer investigations. So that's why we always use CT scan.
But for the non-smoker,
Yeah,
they are not in the screening program. So how?
No. Do you want me to take that one, Grace?
Yeah.
So
Okay.
at the moment, screening is only offered to smokers or ex-smokers. For non-smokers, there is no early intervention at this point. We would only be looking, same with lots of other illnesses, if someone is displaying symptoms. So that would be presenting at your GP. And then you do follow the same kind of similar diagnostic pathway, but you have to be at a point where you are symptomatic and you are displaying those. It's all done on risk. So the services that are put in place, we're targeting the most high risk people who are more likely to develop lung cancer. So the non-smokers at the moment, no, currently don't meet the criteria, but that could change going forward as services evolve.
But for the public, so for the non-smoker,
Uh-huh.
any message to them that they can help themselves to alert of the lung cancer?
Yes. So if I just go through the campaign materials, there might be some materials there that we can use. So if I flick through, so it's a bit different, like I said at the beginning of the campaign. So we have these kind of two elements because we are talking about a screening program, which is for people who aren't necessarily displaying symptoms, and then awareness of people who are displaying symptoms. So you'll have two sets of assets. The ones that you've seen, like the bowel cancer posters, which has been up and about, they will be focusing specifically on lung cancer screening. The people that we're targeting for this campaign are a primary audience are people aged 55 to 59 who are still working. We know that this is the cohort of people who are eligible for screening, who don't necessarily always partake, or when they receive their invite, go along to the session. White males as well, we see predominantly within the data not taking up the offer, and similarly within the Pakistani and Chinese community, there were lower uptakes of screening. The secondary audience for the campaign is the family and friends. So this image that you see in the middle here, they're still here for my friends, for my family, for my team, for my colleagues. The artwork is still being slightly tweaked. But we have got until the 10th of November to finalise it. But the idea is this is all around lung cancer screening, and this is who we're trying to target here. Similar to other campaigns that we've run, we're going to be doing a mix of out-of-home advertising and also social media advertising. So that will be on Instagram, Facebook, the same kind of platforms before, but very specifically geo-targeted. bus shelters as opposed to buses this time round, and digital boards. And we're really going big on radio segments here that complement the assets that we've got. So in this scenario, it says still here for my grandchildren. There would be almost a kind of scripted skit of a woman talking about being around for her grandchildren. And we've got similar ideas in terms of a man playing football and wants to be there for his team, so he can still go along and play at the weekend. So we're really kind of linking the radio assets with the promotional material that will be on boards and across social media. The bit that you're talking about, Felix, is that lung cancer awareness asset. And Grace mentioned a really great organisation at the beginning of the webinar called the Roy Castle Lung Foundation. And I will send you all links to that. But they have lots of promotional material that talk specifically about people who have symptoms that might not instantly be recognisable as lung cancer symptoms. Again, like Grace said, so shoulder pain, back pain. The materials that you'll be being sent by us will be printed materials, and they will all be lung cancer screening. So you will receive wallet cards, posters that look like the one on the right hand side of the screen here. And as per usual, we'll send you the toolkit with suggested wording. Because this is a bit of a dual approach, you'll have wording that's linked for general cancer awareness, but also for lung cancer screening. And I'll be very clear about what assets you're using for which campaign there and what wording to use, because we know that there are two slightly different audiences here, but the main focus of the campaign is the cohort of people who are potentially asymptomatic and being invited to screening over the age of 55. All of the assets, I know we've had microsites before that you've all become familiar with, but we're actually going to be hosting these materials on our own website. So again, I will send you the links where you'll be able to download the full toolkit like you can always, and all of the images and associated assets. The hashtag, we have to have one for every campaign this time, is still here. So Felix, in answer to your question, hopefully there's two lots of promotional materials and sets of information that you can use. So one for the lung cancer screening and one for cancer awareness. And as I said, I think we'll put together a really kind of or an outline schedule for you, so we're not confusing the messages. So maybe 1 week there would be a post around general cancer awareness, and the second week there would be a post around screening. But I will send more information across to you all. Does anyone have any questions on that? No. Okay, brilliant. There's just a few housekeeping things from me at the end, as there always are. So Katie has very kindly offered to join potentially virtually, but also maybe in person, any of the events that you're running from the 10th of November onwards, to deliver some of the messages that Grace has run through today, and also some of the smoking cessation information. So if anyone is interested in having someone at their event from InHealth, please do reach out to Katie, and I will provide her contact details after the session.
Or if they need any information about the screening program stuff, just
yes, or any further
anybody
information.
wants to know anything more, we can provide anything anybody needs to know.
Yeah, absolutely. So I'll send you a big email, as I always do, with the toolkit and everything, and some links to the website. But Katie and Grace are your kind of go-to if you have any follow-ups. And then I just wanted two kind of unrelated plugs in terms of the digital inclusion sessions that are being run by Superhighways. I know that some of you have already taken them up on that offer, and that's great. But please do get in touch with Kate if you haven't already scheduled it. It's part of the package that's been offered to you, and it's a great resource. She has a whole slide deck and presentation around the NHS app and how we can, the importance of it in the NHS going forward, but how we can make it work for people. And she can be there to offer real practical support to people if they want to set up an account and register. And then the other ask is around, I know you've all done phenomenal work around bowel cancer, but please don't forget to fill out your evaluation form by the end of next week, so we can release the next round of funding to you. I think that's it from me. I did see some comments in the chat pop up. Do I need to go back on any of those? Oh, great. You've already responded, haven't you? Fantastic. Thank you. Right. Thank you all for joining as per usual. The recording will go up on YouTube, so I'll send it out so everyone can see it who wasn't able to make it today. Thank you both to Grace and Katie for joining. It was really great to have your kind of clinical insight into the screening program. And yes, I'll be in touch with all of you soon. Thank you.
Thank you. Thanks, guys.
Thank you. Bye.
Thank you.
Bye.
Thank you.
Welcome. Bye.
Thank you. Thank you.